starting to use that with our scopes. Our first round seemed to have worked really, really well. When I called back all the patients, they seemed to have had a good experience. And it sounded like they got out of phase 2 a lot faster as well. We'll have a couple more rounds of testing just to make sure it is something that we want to go ahead with, but getting some education is always good. Make sure everybody understands how ketamine works, some side effects, adverse events, those types of things to look for patients that are contraindicated, all of the good stuff. So ketamine is an NMDA antagonist. We'll talk about a little bit more about that later. It's used as an anesthetic. It produces a catatonic state and a dissociative state. So all of you have seen those patients come out of the operating room and they're kind of maybe reaching for things or they're not clear-minded. Some it becomes quite bothersome, and we'll talk about that later, and how we can better manage those patients if they have some adverse effects that are not allowing them to progress to go home and those types of things. It's an analgesic in low doses, and that's kind of what we're going to be using it with these scopes, is just trying to get them over a difficult spot during the case, not using it as its lone anesthetic. Can be very effective in crisis situations, tolerant patients with severe pain, unresponsive, and high dose of opioids. So patients that have high tolerance of opioids, the addicts, those types of patients, it's just a really nice drug that kind of bridges and allows to get through some of those difficult times or when those opioids just aren't going to work. Analgesic doses typically start at 0.25 to 0.5 milligrams per kilogram bolus and infusion at 5 to 30. Again, we're going to use 10 milligram increments up to 50, is that correct? Kind of what we're trying to reach for. Side effects, although they are rare, these doses include hallucination, sedation, and sympathetic stimulation. So your blood pressure is going to raise, your heart rate is going to go up. You don't see it all the time in all the patients, especially in low doses. It's something to think about if you have a patient that's compromised cardiac-wise, somebody who's already starting with high blood pressure, just to have it back in your mind. It's transient, it doesn't last very long, but certainly something to be watching for. Very little, less than opiates for respiratory depression, so it's really, really great drug, safe drug to be using. It is synergistic though, so if you're using your narcotics with it, it will, that narcotic is going to be a lot stronger. So kind of why we're trying to stay away from the narcotics and sticking with the benzos, just to keep it a safer route for our patients. Can be implemented on the floor, so Regents does have it as part of their pain control at a very low dose. Again, it's the 10 milligrams. It's on their protocols, so that was kind of fun to see as I was trying to research different ways of providing pain relief here as well. And it provides anti-anxiety components. It's very inexpensive, which is nice. I think like a vial is like $10 the last time we looked it up, so that's great. Extremely opioid sparing, which is nice that we talked about. And prevention of conversion to chronic pain. So there's been studies that say that even the 50 milligrams that we're giving in the operating room, it is supposedly is showing that later in life these patients are sparring chronic pain. And I don't know how they've come to that. It may improve post-op rehabilitation when compared to IV opioids, ability to decrease the post-op up to 6 weeks in consumption. So that was really cool. This was a study done on some post-op knees. And they showed that the consumption was significantly less in patients who had ketamine as part of their pain control out on the floor prior to going home. It's an NMDA antagonist. It works at the analgesic and anesthetic. It reverses hyperanalgesia. So you've seen those patients where you keep giving narcotics and it seems like they're getting more and more painful. It's because of that upregulation of the receptors, and so it's not working anymore. Those narcotics aren't working anymore. You're thinking, oh my gosh, this patient must use drugs at home or what have you. They may be a chronic pain patient, but now we've upregulated them to the point where those narcotics aren't working anymore. And so I've seen a few of those patients here, and I don't know who I've worked with, but I come out with my ketamine and said, hey, let's give them 10 milligrams. And it seems to work and reset those opioid receptors, which is kind of cool. And there's a lot of literature that's kind of supporting that as well. So it might be something that you'll see in PACUs in the future more often. I mean, we'll see it here and there, but it's not a standard. Ketamine binds the receptors in both the peripheral nervous system and the central nervous system as an antagonist to those NMDA receptors. It inhibits the binding of excitatory amino acids, these receptors blocking that painful stimuli. So blocks it at the receptors versus like the opioid receptors or the mu receptors and those types of things. IV administration is within 30 seconds, which is really kind of cool. So we don't have to sit and wait that time period for full effect within 1 minute. The duration of IV ketamine is up to 60 minutes. And I've seen in the literature it says 15 minutes up to an hour, and I think it's dose dependent. And the half-life of ketamine is 2 to 3 hours. So ketamine inhibits reuptake of the dopamine and serotonin and elevates the circulating epinephrine and norepinephrine levels, thus increasing heart rate, blood pressure, cardiac output, and vascular resistance. So like I said, you'll see that increased heart rate or increased blood pressure. It probably lasts less than 5 minutes. The adverse events or effects include the vomiting, increased salivation. So we talked about making sure we have glycopyrrolate to make sure that if those patients are salivating, they're coughing or sputtering, that you give that to them so that they don't learn to spasm, because that would not be a fun event to have down in scopes. Increased intracranial pressures, so patients who have a lesion of some sort, tumors, any sort of things that you don't want increasing intracranial pressures, you would not want to use ketamine, but I think our patient population, you just won't see it. Vivid dreams, hallucinations, so you're going to give the benzodiazepines. They said up to 50 milligrams, you should not have those effects, but I've seen it. I mean, I think you're gonna see just those outliers that will have just the extreme effects. Because I've given 50 and all of a sudden my patient is out of their mind, and I've given the Versed. The literature says up to 50 you should not need to have a benzo, but I think our protocol, we're always going to give that benzo. And then some patients will have a weird reaction and have some hypotension, but I have not seen that. It is metabolized by the liver, and then it's excreted by the urine. So patients who have severe liver disease will probably stay away from the ketamine, just so that they can excrete it and they're not out of their mind for days. They'd probably appreciate that as well. So like we said, the onset's quick, just different ways of giving it. Duration of action, like I said, 5 to 15 minutes up to 60. I have not used it epidural. I don't know that I've seen that used, but the literature supports it. Let's see, I feel like we're repeating ourselves. So it's an NMDA receptor antagonist. Just saying that naloxone is not going to reverse it. It will, at high doses, go on those mu receptors, and that's where the opioids have their effect. And so the naloxone will not reverse the analgesia. So just really watching your dosing. Up to 50 milligrams, I don't think we're going to have a problem. The MOA acts on the thermocold pathway and limbic system in the CNS that blocks the membrane effects of excitatory neurotransmitter glutamate. It produces that dissociative state. So that's the mechanism of action and why they're dissociated. And you'll see the nystagmus, their eyes will tinker back and forth. Typically not seeing that till probably getting towards that 50 milligrams. Patient will be awake, but unaware of his environment. Eyes open intact, corneal light reflexes, and slow nystagmic gaze. Produces a profound analgesia and amnesia. So we saw that where our patient was looking at us clearly, awake, but not really caring what's going on. And that's kind of what we wanted to make sure when we were calling back, that they don't remember anything, because it's really, really hard. When I use it, I'm using propofol, and so my patient's clearly sleeping. So we just want to make sure when we're calling these patients back that they don't recall any of their procedure and that we're giving enough. And it seemed like everybody was comfortable. At high doses, ketamine has also been found to bind the opioid mu receptors and sigma receptors, like I talked about. This indicates a loss of consciousness at high doses and may partially due to the binding of the opioid mu and sigma receptors. So they will use it as a general anesthetic and for induction of general anesthesia. So they'll induce with ketamine and use an infusion just as we do with the propofol. And that's how it works if we use it that way. Let's see. So it just talks about that those NMDA receptors affects that memory and thought, so that they forget what we're doing with the procedures and the mechanism of action of why that works. So contraindications are uncontrolled hypertension, stroke, intracranial mass or hemorrhage, pregnancy. I don't think we'll be using it with any pregnant women. Caution and head trauma, the ICP, IOP, so severe glaucoma is something that we probably should really be watching for in our patients. coronary artery disease if it's unstable CHF. Again, patients I don't think we'll see too many here. Psychosis, if they're already in a psychotic state, which I don't think we'd care for those patients, we would not want to give them ketamine. That just would not be a good thing. And severe hepatic impairment, because that's how it is excreted out of the body. Anorexia, nausea, and vomiting, so making sure that we're giving our antiemetics. So being part of the protocol, giving that Zofran, because it does have a nausea and vomiting component to it. Elevated blood pressure, heart rate, diplopia, so double vision, nystagmus when you're seeing the eyes back and forth. I have not seen the fasciculations, so fasciculations, it's just kind of like convulsion, like their muscles are twitching back and forth. You maybe see that, it's just transient. Depressed reflexes, so watching the airway, hallucinations, bradycardia, hypertension, and some cystitis, which I've never seen, but all of those things are possibilities. Uncommon reactions, respiratory depression is very minimal. Laryngospasm, just because of the increased elevation. Increased IOP, severe hypertension, bradycardia, arrhythmias, emergent delirium, which we've seen a couple of that happen. Hallucinations, tonic-clonic movements, and anaphylaxis. So all of the possibilities, but are very, very low profile. You have a question? Anyone? No? Okay. Cardiovascular is a direct myocardial depressant. Over-invited central sympathetic stimulation, neuronal release of catecholamines inhibit that reuptake of catecholamines. So depresses the cardiovascular system. So patients who are already cardiovascularly compromised, we'll just make sure we're not using ketamine. Increase in systemic arterial pressure, heart rate, and cardiac output. Pulmonary system, this is what I like about it. It's a bronchial smooth muscle relaxant, so it stimulates that B2 receptors in your lungs, so it bronchodilates. So patients who are asthmatics, any of those patients, it's pretty great for. And that on top of not being a depressant respiratory-wise makes it a pretty safe drug. As effective as inhalation to prevent bronchospasm. So see those patients who are doing MAC cases, all of a sudden they start coughing and coughing and coughing. And Dr. Singh's like, stop moving! And they're bronchospasming, and it's, then I'll reach for my ketamine because I know that's going to bronchodilate. I can't have them using a bronchodilator as I'm using a MAC. They just wouldn't be able to do it, but it does work, and it's pretty cool because then they stop coughing. Another thing that you could do if they do start coughing is give a little, because then if you have, it's kind of back and forth. So if you have a patient who has COPD, and all of a sudden you loosen up that junk and they're coughing to mobilize the junk, give them a little bit of fentanyl, a little narcotic, to stop that coughing. Increased pulmonary arterial pressure increases salivation. So again, just really watching for having your suction, making sure you have that robenol glycopyrrolate to dry them up. Seizure threshold's not altered, so that's great. Increased cerebral metabolism, blood flow, and ICP, like we talked about. Increased uterine tone without adverse effects on the uterine blood flow. It has a safety profile for pregnancy or pregnant women, but I just wouldn't use it. And doesn't release histamine, which is great, so you won't see that profound hypotension that you'll see sometimes with the fentanyl in most patients. So here's some trials that they did. So there's 2,240 participants, and it's an old search from 66 to 2004 randomized controlled trials. And so what they found is that the subanesthetic doses of ketamine reduced rescue analgesia requirements, pain intensity, and morphine consumption, post-op nausea and vomiting when they were using it on these patients for post-op care. So it's just really cool that they didn't have to use so much of the narcotics if it was given during the early phases. And so the adverse effects were mild or absent, and so it had a really great safety profile. And so for us rescuing some of these scopes, it does have a lot of strong literature to support that. Here's patients who had upper abdominal surgery. They were given some remifentanil, which is a fast-acting narcotic, throughout the case. And then they were giving ketamine throughout the case. And so what they found is that the large doses of the Remi triggers the post-op hyperalgesia, the upregulation that we talked about, so that the post-op opioids weren't working. So then they gave small doses of ketamine throughout the case, and they found that they had better pain control afterwards, and they didn't have that upregulation. That's all I have for you today. Do you guys have any questions at all?
It seems pretty clear that that it works great. I mean, but so this study was in 2004. How come we haven't seen more of it before this time?
Because I thought about that too as I was putting that in. It's hard to change people's thoughts and what has worked for them. I mean, giving Versed and fentanyl has worked, or having propofol as the new standard. But for us, we're trying to be more creative. And I feel like our hospital thinks outside the box a little bit more, and we're willing to utilize our literature to support some of those things. I work at Regions casually right now, and I want to reach for my ketamine, but it's not in the culture. The ketamine, that nobody uses it. But the literature supports it, and it is an old drug becoming new again. And so it's just kind of that late response to something that I think is a pretty great drug to use.
Can you use ketamine just independent of any
So
benzo?
you can, but they say up to 50 milligrams you can use it without a benzodiazepine. After that, those hallucinations and would just be so uncomfortable.
I'm just wondering, there are a lot of people who would like to have the opportunity to work the graveyard shift that night, and we don't allow that, but with ketamine, it clears rapidly enough that, at some point, if that's an opportunity for people.
I'm confused, what are you talking,
Well, most of the time, it's 24 hours, can't drive, they can't go to work.
oh, I see what you're saying.
So if they had that opportunity, that might be a nice thing to offer people.
Right, just ketamine, okay.
Because of how quick
Wouldn't
it
the rules
clears.
still be the same? You wouldn't let them
I
drive
still
first?
wouldn't.
Well, you
Yeah.
wouldn't let them drive, if it clears that quickly.
Right. It is nice, and I think you'll see that too with the patients, because they're not going to get what really makes patients feel cruddy for a long period of time is the amount of Versed, because that's a hold on for a long time, and then it doesn't clear in the elderly.
Right.
And so these patients, they have studies that say, you give your elderly patients Versed, you can have them confused for 6 months post-op. It really, really affects them. And so for me, if my patient is greater than 70 or has some cognitive disability or some dysfunction, I don't use it at all. They
Right.
don't get Versed.
That's why I'm wondering if we can trial it without the benzo for some.
I would probably still, like the elderly, I'd still probably give one of Versed, just because I wouldn't want to see them having those side effects. I think it kind of outweighs that a little
They
bit.
forget them typically. They have them, but they forget them,
Yeah, it could be
At
a
the
traumatic
time,
event if they
yeah.
didn't, I guess, is my only concern.
yeah.
Well, even though it has an analgesic, correct me if I'm hearing you wrong. So I'm hearing that it also has an analgesic effect, but it
Low doses
also
it does, yeah.
elevates the little bit of fentanyl that we're using.
Right,
So,
Yep.
yeah.
it potentiates the fentanyl.
What are your thoughts about not doing any fentanyl?
Yeah, that's what I'm thinking.
And you could absolutely try that too. And use it only if you need to. If you're kind of seeing yourself using that ketamine increase, well, one of fentanyl is not going to, you know what I mean? And each patient's going to be different, as we all know, have different requirements, but
At what level, let's say you've started down the path of Versed and fentanyl, let's say you're at 4 and 200, is
Okay.
it too late to add ketamine? Where would you say,
if your patient is really uncomfortable and you're still at a point of some significant stimulation, I would start at that 10. I don't think that's a problem. I mean, if they're being stimulated, they're still wanting to leave the room, I think 10, increments of 10 is still very safe.
Where would you start it if you could, like you're at, what'd you say, 4 and 200? Would you start it at 3 and, if you could choose where to start it when you start bumping up these drugs, where would you?
I would give 2 of Versed, and then I would start my ketamine, and then use the fentanyl if I needed to.
So you would not start with 2, because usually we start with 2 milligrams versus
and
100 of fentanyl.
And that's okay too. I mean, it seemed to work well for us.
Right.
If I were doing the anesthetic, I'd probably start with my 2 of Versed, give some ketamine, see how they're doing, and then start adding in.
So you would automatically start every case with ketamine?
I personally would,
Okay.
but
But if we're starting with 2 and 100 to
Well,
try
I'm just saying, actually, maybe we want to just get away from the narcotic at all, because it has really good analgesic effect.
it does. Right, and maybe the next trial that we do, we start that way and just see where it goes. It's a good idea.
Do you find though that sometimes people on the ketamine get a little excited? I mean, they get a little, even though they don't remember it, you have to get past that, because they'll do some, oh, you know, sometimes.
Right, so I think when, like I said, when I'm using it, I'm using propofol, and
Right.
so I blunt
You don't
that, I
see
don't get to
that.
see that. But when we did our trial, we didn't see it.
Oh, you did, okay,
Mm-mm, they just kinda got this gaze,
right.
and then I'm like,
Looking into know.
and it's hard for me because my patients are asleep, you know what I mean? They're not looking at me. And so for me, it was just wanting those phone calls to make sure that even though they're looking at me, they were still comfortable and not remembering,
Yeah,
so.
well, I've used it other places, and it was, some people get real excited with it, and they, even though they'll never remember it, and you can just usually say, it's okay, just relax.
Right.
And
I
you don't
think-
wanna stimulate them, you want them to be,
Yep, but I think using the benzo or the fentanyl will kind of take that edge off for them versus just the straight ketamine.
I think for the small doses that we're giving, we wouldn't need to do the Robenal, just as long as it's in our rescue kit.
Right, I don't think it's something you have to use all the time if you see a lot of salivation. Some of these patients you see, they come in slimy, right? And just having it back in your mind, that's something you may use. And the fact that we have them turned is nice because it's just kind of drooling out.
Something to avoid with uppers, just kind of just do the standard first fentanyl, so you don't have a lot of salivation.
You know, I would use glyco for the uppers.
Okay.
Yep, I would just give the 0.2 of glyco up front, and then I love ketamine uppers because then I don't have respiratory depression.
Yeah.
That's always my thing. If I respiratory depressed, now I'm trying to be in your way, trying to jaw lift, and then you have to stop because I need them to not be blue. So,
most of the colons come in kind of dry to begin with.
Right.
They're dehydrated, so
right?
they don't usually have a ton of salivation with ketamine, I don't see it
No, it's probably true.
typically.
And you said you would automatically give the Zofran if,
I would.
if you're
I would
giving
start
ketamine.
Right.
Every time?
I
Lesson.
would use it every time, personally. I mean.
Before you even
take
start the
care of one
ketamine, you'd give it just up front or just?
I'd
So
give
we
it
need
a
that in pre-op?
You could even do pre-op.
Oh,
It could be part of your pre-op. It'd
We're
be
gonna
nice.
increase our costs.
Is Zofran that much?
I don't
I
know.
don't.
I don't know.
I think now that it's generic, I can check with pharmacy on that, but I don't know that that's a huge increase in cost.
And so who is gonna be screening our patients that cannot get it, the ones that are contraindicated? Will it just be up to us when we're reviewing the charts?
I think just making sure you,
Okay.
if there's cardiac history, if there's any neuro history, that you're just giving a heads up to Dr. Singh and just saying, hey,
Glaucoma.
what's that? So
Glaucoma.
glaucoma, any brain lesions,
Liver.
hypertension that's not well controlled.
Okay.
Yeah.
We kind of talked at the meeting yesterday of maybe having a little checklist just initially, so that we're double
Right.
thinking when we're
That's a good
checking
idea.
charts.
Well, we could add it to the smart phrase
Yeah.
so that it automatically got asked.
When you say cardiac, you're gonna find that on probably 50% of our
So
people,
it's
so what are you talking?
severe, I mean, it's gonna be
So
severe
uncontrolled or
cardiac.
severe?
Right. So
So we
like
don't
your-
really, probably not even gonna be doing it, or
Yeah, if
anesthesia's
they're
gonna be doing it.
unstable.
Right, so
Yeah.
severe CHF,
Mhm.
you know,
It is.
severe cardiac, disease, yeah,
Which is ones that probably should get ketamine.
right. I mean, there's gonna be so far and few between.
And if you spoke that nausea and vomiting was also a contraindication?
It was an adverse effect.
Okay, I
Yeah.
thought I saw it both.
Well, maybe if they're nauseated, it'd be something I did up front. Maybe it's
Yeah,
something
if they
I
come
would
in
personally kind
sick.
of come back, but,
If they come in nausea?
right,
Okay, then we will.
and you could.
Okay.
It's just
Well,
gonna
just have
be,
to go
it's just
for it.
gonna, right,
Okay,
Yeah.
fluids and Zofran, okay.
right.
Then we should give them a little time at the end of the case and just to kind of not wake up, but come up, be more alert, or is it okay to go, okay, let's get going, you know?
I think they can go right to phase 2. I mean, they're not awake. I mean, they look like they're awake, but they're protecting their own airways. I mean, the ketamine has allowed not to get to that point of deep sedation, right? Because sometimes, when we're coming in, we're knocking on the door of general anesthetic. When we're lifting an airway, we're pretty close to a general. And so for the ketamine, it just makes them have a less level of sedation. And so I feel like they can move right out to phase 2.
It seems like at 25 to 50, it only lasts 5 to 6 minutes at best.
Yeah, and the literature is saying, like I said, 15 to 60, but I think it's dose dependent,
It's probably the narcs you gave before.
right?
I mean, the ones I've given with just Versed and ketamine, usually get a nice 5-minute window of doing stuff where they're
Right.
not really responding.
Which is kind of nice too.
Yeah,
What's in the syringes? Is it a 50 milligram per 1 mil or?
Right.
Okay.
And I think it would be nice to ask pharmacy to dilute that down for us, so that it is
So we can
1-to-1,
Yeah.
right? No, 10-to-1, 10 milligrams per 1 cc.
what's it right now?
It's 50 to 1.
50 milligrams in
Is
one
this Karen?
cc.
Oh, I'm
It's
sorry.
a 1 mil. It is,
Yeah.
it's kind of a guessing game when you're trying to get 10 milligrams, but
Are they able to dilute that?
we've had it diluted like that before.
Okay.
Mhm.
Is it a drug we're gonna have to waste with each other
Right,
at the end?
yeah. But that would be nice if you guys could do maybe 10 milligrams per 1 cc.
Yeah, that'd be a lot easier.
For the nurses and
Right.
less room for error.
Right, yeah.
I think the main focus needs to be that it is really truly a partnership between you guys as the nurses and Dr. Singh as the provider to make sure that there's communication happening before a patient receives ketamine. That, you know, we've done our part of checking the chart and knowing the history. You know, he's looked over the chart too, knows some of that history, and having that conversation if there's concerns before we administer it. And if ever there's a question, or if ever you think more support is needed, we have anesthesia available, so.
Would it be helpful if I came up with that checklist of patients?
Yeah, I think
Like
so, because we can
precautionary
touch some of
patients?
it right in as we do pre-checks on
Yeah.
charts. And then the second check would be the smart phrase.
So if we came up with a checklist of precautionary patients, that
Yeah.
should
It'd be our.
spark
we
a
can flag the
conversation.
check, yeah.
Right, yeah, okay. I think that's a good idea.
So how long of a trial is this gonna be before?
I think, how many more, do you want another 1 or 2 days, or what is it?
You know, for me, it's, you know, we've done a couple more just randomly here, and it seems to have worked really well. So it's really kind of up to you guys. I mean, I'm comfortable with it. It's just kind of, I think, a matter of doing that chart check. And, you know, I kind of like just the ketamine Versed and trying to avoid the narcotics completely so we don't have this
Right, and you're gonna,
respiratory issues that, I mean, you can always add a little bit, I think, afterwards if you want to, if we're
Right.
with that.
yep. But I also
I'm
think,
kind of open to whichever, I mean, it's up to you guys, really. I don't have a strong preference.
right, I think you'll know when you're gonna have to use that fentanyl, if
Yeah.
you're just not getting that pain control, or, I think that's a good idea.
Is there, like a second pass though, up in there?
For, no, no,
The second one?
Second one.
so it doesn't.
Like pharmacology wise, like is there a second pass? Like that the patients would have to be aware of going home?
No.
So, and then, right now, it's just Dr. Singh,
Mm-hmm.
and then what about Dr. Miller, Dr. Drucker, in the
So
future?
once we get things situated with the process and our protocol and how this is going to work and get it kind of underway with Dr. Singh, then we will offer it to both Dr. Miller and Dr. Druffner. No, Dr. Druffner's gone, so he wouldn't start until he came back anyway. So, but we'd want to make sure they have education and are knowledgeable about the same sort of effects that Dr. Singh is aware of. So that will be a little later down the line. I think first we need to look at our process. It sounds like we maybe need to do at least 1, maybe 2 trial dates with no fentanyl to start and see how that works. And then make sure we're calling our patients. In fact, I would almost start recommending that we start calling patients all the time right now, just to get that feedback as kind of a basis before we start implementing this. And then while we're kind of doing these trial periods, we'll work on the checklist and adding it to our sedation policy and those other pieces, making sure everybody else who's not here today gets the education, and hopefully within 2 to 3 weeks, we can start using it every single time.
When you make your post-op phone calls, is there like a checklist form or?
Yeah, it's on Epic, there's a tab.
So is it where they rate how they feel, or is it just more of a yes or no, or how?
It's more of like, we only do surgicals, we don't do colonoscopies right now, but on the surgicals, it's like, do you have any bleeding or drainage, fever, nausea, vomiting, any unrelieved pain, any reason you had to see the doctor in the last 24 hours?
We
Do you
can
have
make
any
it whatever
questions?
questions you
No,
want.
but isn't there like a, in terms of a scoring system that people can rate in terms of right after and also then when they call back?
not presently, but we could develop
We
a
can
smart phrase.
sure do it.
Well, I'm just wondering if it would be an interesting, because there isn't a lot. Well, did you see a lot of articles on colonoscopies and maybe be a nice little report for you to publish, Dan?
Well, you. That's
So-
what he told me, I was like, you
Karen,
can publish it and put my name on it.
So you know what we
Is
could,
that what you said?
we could do
Great.
is make a smart phrase
Follow.
to ask post-op immediately and then have that smart phrase as a note for the callback, because the callback, the surgical callback doesn't address any of those things.
Mhm.
It's bleeding, you
No,
know.
it's just more, I think there's like anesthesia has like post-op scales, I mean, that they've used, I've seen with other studies.
Right,
I mean, is there any, incorporate one of those in there?
we could look at that.
Yeah.
It would
It'd
be
be
nice.
interesting to find out, because if you can,
Right,
just
I
need a
could
couple
come up
hundred
with-
people, which wouldn't be very long to tabulate to see what kind of.
Right.
And they would probably feel really cool as patients, like you're part of our study.
Right.
But if we're gonna do an official study, then we will have to go through an IRB and
Oh.
that's. trust me, you don't want to-
But you know, on
Actually,
the,
actually, that's
Don't
not an
say
official study.
study.
It's more of a, you just, because you can actually look back and just say, if you look at just your case, that's case study.
Yes.
Not a randomized control study. So
Right.
this is more just as a case report on
Correct,
200 patients that we did. So then you don't have to really,
right. But if you're telling patients they're part of a study,
Yeah,
then
no,
you
no, then,
do
yeah,
need
we
to
don't
go
wanna
through
do
an
that.
IRB, so.
let's not.
and
do that.
on the other hand, the last time we did it, I had patients come in and they'd say, I hear you're using a new drug. And so I don't think that's appropriate to tell, like,
Yeah.
when you're admitting the patient, I wouldn't,
Yeah.
Tell
yeah,
them
because
the
then they're
process,
like,
yeah.
I'm a guinea pig.
Yeah.
Yeah.
yeah, and you're what, you don't really know how this works. And so I had a couple patients that day that were like, do you know what you're doing, or,
Why do you have to tell them anything?
Well, that's my point, is I don't think we should tell patients. I don't think we should
No,
say,
because I think.
we're in a
just
study,
since
we're in a
anesthesia's here,
research,
I think
yeah.
as long as, since we don't have an official protocol,
Right,
and
but
they
they
use it
don't.
all the time.
I don't think the
that's-
patients need to know
They,
that.
we need to.
But in the
worry.
past, though, we're saying, we're gonna give you some Versed and some fentanyl, so then you want us to just say
And
those
you
two?
may, well, we
Yeah, our
use,
spiel would change.
Yeah.
we can use 3 drugs, with
Why-
fentanyl, Versed,
I
and
don't
you might
even
get some
name the drug.
ketamine.
I
Do the
just say
patients
sedation.
ask what you're using?
They don't know, do they?
No,
Occasionally,
people
they
do.
don't know.
Like,
yeah,
they've been
occasionally.
here before,
But
they
I mean,
know.
if you want to,
They
you
might
can say you
ask.
may
I
get
think people
fentanyl, Versed,
ask,
and
it's fine, but
ketamine.
I don't think
I
you have to
mean,
go in
I would just say, we're going to give you some moderate sedation. And if they ask specific drugs, then you can, but I wouldn't just,
right.
I wouldn't increase anxiety over.
No,
Other
but
than
that's my
like, oh my
point
gosh,
is,
ketamine,
is
that's a
it
vitamin
should
D
not
drug
be
out
the
on
admission to
street.
tell people that they're getting a new drug or that we're
It's
trialing
not
or
a new
that.
Because it's not a
It's
drug.
it's
But
a-
it, even trialing or,
protocol,
and new
right.
protocol, any of those, nothing. I think it should be, we do this every day, have done it for years, kind of thing.
Well, we do, just usually anesthesia's running it versus the nurse is running it, and so
Yeah.
that's the difference. It's just the person who's
Administer.
there to administer the medication.
So the questions that we came up with during that first trial of patients was, do you remember anything? Was there anything you wanted changed, just so that they had an opportunity to say, oh my gosh, I felt crazy, or, you know what I mean, that they could put their own words to it? Were they nauseous? Did they have pain, remember anything? And if everybody's like, oh no, I was comfortable, I don't remember anything, I wasn't sick. So it just gave them, like I said, that open question to add whatever they wanted. And out of, I think there was 5, they all were happy.
Mhm.
So I think the next one, we should try and use it on a more regular basis, so that would mean that we would need one of you guys there for the whole morning. And
can
just
look
try
at
with
the
every
schedule.
case, so yeah.
Yeah.
So rather than just intermittently, so you're just waiting around or something.
Yep, it's a good idea.
Then you can get those just numbers in and say, okay, fine, we got 10 or whatever you want.
Yeah.
whatever.
So you want this little survey before the patient goes home?
We called them the
And
next
then
day.
you call them?
We just
Okay.
called them the next day afterwards.
Because they might not still be familiar with it when they come home.
But we've thought about asking the survey now on regular,
Yes.
the way that we're doing it now,
Yeah.
so that we've got comparison.
Mhm.
We have that survey. I mean, we can tweak it and start it, do callbacks today if you want.
A
So that,
colonoscopy.
using the same survey?
Mm-hmm.
Yeah,
Yeah.
I think it's a good idea.
Mm-hmm.
I have a little mailbox, and you probably have it on your computer.
That'd be good.
Give Packy for some more stuff to do.
There's no medication interactions with ketamine, is there? There's nothing that you can't give it with?
No, I was looking through,
That's a good question.
yeah, no, I was looking through all of the drug-drug interactions and
Great.
awesome.
Thank you.
You're welcome.
Yeah.
So we'll kind of work on those pieces and then send out more communication around an official go-live date. We'll work to get another couple dates of,
Okay.
and then we might need to look at the order sets to see if you do want to change what's being given initially, if we need to change anything
Okay.
or add anything. So we can review that, make sure everyone's getting the same information.
I think getting pharmacy on board with that one-to-one is the hugest piece for me.
Yeah, I'll send a message to Darla and stuff.
Just because of a safety issue
I think it'd be very helpful.
Yeah.
and accurate dosing.
If we're
You don't
gonna
think you
be-
can just dilute it yourself?
I
They
totally
really-
could, but it would take more time and you like to run really fast.
From a safety standpoint, pharmacy's pretty
Oh,
against that.
okay, all right.
So when we're putting in orders, we're supposed to put in,
And returning it.
are we supposed to put the
Pharmacy
Benadryl
be
in
like,
and the ketamine and then?
Oh, right, and returning it.
Yeah,
Well,
I think
let's-
we
Nurse
probably need
available.
less Benadryl and all that other stuff. I think that the idea is to kind of get away from all that other
Right.
stuff, make it just more simple.
You said Narcan will have some effect?
Will not.
Will not.
Mm-mm.
Okay, so there isn't really anything that will reverse
Yeah,
it.
but I think
other
it-
than time.
Yeah, at this point, we're at such low doses, I
Yeah.
don't think we're doing
But
And
if
they
you
use
were-
it in law enforcement in St. Paul, so, I
Right,
mean, dark guns.
right.
Interesting.
elephants.
That's what people, when you say it, that's the first thing they, shut the stuff they drunk was.
Typically, when you're trying to, when you have to reverse something, it's your narcotic or your benzo, right? So that's typically what's causing your respiratory depression and the reason why you want to reverse it. And then treating some of those, if they really are out of their mind, might end up calling us and giving some Haldol.
I'm convinced that fentanyl does much for these cases.
Doesn't do much?
I don't,
Yeah.
I think it's mostly because you get so much of a depression that they don't respond, and it's really versatile. I think the fentanyl is,
Yeah.
I think it's super.
Yeah, well, it'll be interesting.
All right,
Cool.
thanks.
When we're done, I
You know, we did not give Zofran on the days that we gave it.
So
Put it all together.
Right, and we didn't do that and none of them were sick
If you're ready to go a little earlier,
But-
just let us know.
Oh, I'm ready to go.
for the, you know.
I don't know what time you're thinking.
Because you didn't know which patients were gonna, or did you give ketamine to everybody that day?
I
Yeah,
think we did.
we did.
We gave ketamine to everyone.
I'm sorry, I totally
And we didn't give any of them Zofran, none of them were sick.
So maybe we should save that
I
for
know,
the
I know.
end if
But
they.
yes,
come
I,
to
but
us
I
just
think
afterwards.
if it's not expensive, I would rather.
I have the listing in the office, but
What's your
once patients are sick, trying to
Oh,
change
it's
some
hard
of
to
Zofran.
kick back.
I should
Okay.
know it, but I haven't had it for.
I always give my antiemetic right up front when I do cases.
So maybe if they come in and say, oh, God, I always get this when I have, you know, I'd be one of those.
Right.
I always get nauseous, so that'd be a person that you'd want to up.
But those are ones that you don't want to necessarily give ketamine to either.
Yeah,
Well,
it's hard though. I think those patients are gonna get sick on the Versed fentanyl too. Any patient that has like motion sickness
It would be nice.
and you're giving any sort of sedation, I mean, they're getting them, they're woozy and they're immediately gonna
Yeah.
be puking.
Docs and their assistants.
I just don't think.
So is the motion
It
sick
is
is one of those questions?
It is, but if we're gonna have a sheet.
The questions we had, no.
But if we're gonna have a quick sheet, I'd like it to be.
But yeah, none of our patients got sick.
And we did not give Zofran,
I think
but,
2 of them got Zofran.
oh, did they? Okay.
But we put that on our,
Oh, because they got it, because they were nauseated up front, because we didn't give it just because of the ketamine.
but nobody puked though.
But nobody puked, and nobody afterwards was sick, so there were two
So maybe that's
nauseated,
the key
there were two nauseated people at the time who got Zofran, who didn't, bless you, who didn't get sick afterwards.
I mean, you could start it with Zofran only to those who are nauseous.
But present with.
Well, if
Right.
it's like $10, I would
Everybody should
say,
get,
yeah. I mean, I like it when you guys give Zofran to everybody, you know what I mean?
that's, every anesthetic should have an antiemetic.
Right, so I am always appreciative when you guys do that, because
Once we get that all
50% of the time when you don't, they're
And
sick.
still-
And you don't know.
So we
Right.
don't have, like,
What's the cost of Rona?
Post-it note
Do you know?
papers
I'll have to look at
everywhere
that too.
now.
I am finding.
I don't think it should be very expensive, but I'll look.
And that's not something we're,
No, you wouldn't get, I was just curious.
Only if they're like salivating. At those low doses, they shouldn't. There was a patient, I'll never forget this, she was MR, so she was, had a mental disability, and we were trying to get her IV in. And I don't